Hi, my name is Laurie Diggins. I'm the director of the Healthcare Integration Technology Program for the IDN 4 DSRIP 1115 waiver. I wanted to give you a little bit of information around healthcare technology and how this waiver is going to affect technology across the state and specifically across the Manchester region. So one of the things that we've noticed in our gap analysis moving across our partners is that technology has been a struggle. Money isn't there and information flows kind of in an unsteady manner, and our goal and principle is to make sure that all of our partners, from the smallest to the largest, have enough technology in place to be able to communicate and send information related to patient care in a convenient and safe way where privacy is protected and we have quick resolution to patient needs. Our project focuses really on a number of different items. Basically, we are looking at supplying a concept called secure direct messaging to all of our partners, and that would allow them to be able to send protected health information data so that it is protected, and allowing the partners to be able to send that information back and forth between each other in a bi-directional manner. This will help to support transitions of care, referral processes, and when we look at organizations who don't have electronic medical records, like some of the smaller, this will be the first time that these organizations have the ability to be able to receive electronic data, and so it's very exciting for them. The second piece really is involving event notification. It has been a long-standing principle around the fact that emergency departments are overutilized across the state, across the country for that matter, and looking at those patients that are high risk and how do we prevent those patients from continuing to use emergency departments when there are much better resources available to them in the community. So with that, we'll be implementing an event notification tool through the collective medical technologies that will allow emergency departments to register patients, and that data will transmit to the CMT product, allowing for providers to not only be alerted when there are multiple visits or that patients have very specific needs around emergency room departments, but will also allow treating providers, behavioral health providers, and PCPs to be able to receive alerts when patients that they're attributed to are seen in an emergency department or made an inpatient in a hospital organization. The next piece is focused around EHRs and developing EHRs to be able to make sure that we are addressing all of the behavioral health needs for the community from both a primary care perspective and behavioral health. So with that, the waiver focuses on what we're calling a core standardized assessment, which allows us to look at social determinants of health and making sure that we're screening patients for social determinants of health and their risk around them early in the visit, so that we're able to prioritize and work to refer and develop some sort of intervention to hopefully improve that patient's lifestyle. These core standardized assessments will be incorporated into EHRs through a number of technology pieces. Patient Link, which is a tool that allows us to be able to capture data through a patient-facing document, is one of the ways that we're going to be doing that. Other organizations will be incorporating it directly into the EHR. The good news about this is that it really allows us to be able to, again, as I said, get upfront information rather than waiting or reading through provider notes to be able to identify risk. It lends to a smoother workflow and allows us to have better ease of electronic referrals to those community resources. Beyond those tools, we're working with a number of organizations to enhance their EHRs to make them more functional. We even in some cases have organizations that don't even have Wi-Fi at this point, and so allowing them to do that. So our plan is really to make sure that we basically have three tiers of individuals. We have those strong hospital organizations who have powerful EHRs, who have a lot of functionality. We have those mid-levels who have some EMR functionalities that need some support, whether it's testing or integration to hospital systems to get information. And then we have those smaller organizations that need full development of an IT structure, and we're there to support that. Our budget is divided in a way that we are focusing a lot of time on that B1 integration piece where we're looking at integrated healthcare, but we also realize that despite the fact that some of these groups will become integrated, we also have a lot of small partners that really are necessary to make true integrated healthcare work and obviously to make true intervention. And we need to make make sure that those people are accessible. The long time hope of this project and the HIT needs is that we have a structured, communicated community so that we're able to send data from one location to the other, that we're able to make sure that we are sending that data in a protected way, following guidelines and making sure that we're keeping patients and patient information safe, but also allowing us to be able to accumulate data and understand. One of the great things about technology is it allows us to be able to use it for quality information and being able to understand some population health data. When we're asking the 20 social determinants of health, we're looking at answering those questions and then understanding the population and what percentage of people are really struggling in areas of employment or transportation or just financial needs to take care of their health care, and how are we addressing those. We've never been able to be at a place within the Manchester region to understand truly with strong data exactly where our patient needs are, and the technology we're putting in place will allow us to do that. Through systems like closed loop referral, we'll be able to accumulate that data, make small partners stronger, make larger partners have stronger and better workflows, and continue to build a community of healthcare rather than just a lot of people who are trying really hard to affect the patients and make things better in the community.